confirm live.
So I'll just wait for it to strike 10 and then start, Amanda. Good morning, everyone, and welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. I am Councillor Karen Calder, and I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to hear the audio of the meeting and view the papers shown on the screen. The meeting is being held using remote technology, and should any committee members experience technical difficulties during the meeting, they should immediately contact the designated IT officer on the number they have already been supplied with. Everyone is requested to mute their microphones unless asked to speak. Please only use the chat function to indicate the desire to speak. Do not use anything else. As the Chair, I will interpret the Council's existing standing orders in light of the requirements of remote participation, with advice from the monitoring officer to make a rule prior to making a ruling. At the start of the meeting, I will ask members of the committee to confirm their presence and any disclosable pecuniary interests they have in any of the items on the agenda. I will ask everyone invited to speak during the meeting, including members of the committee and officers, to introduce themselves before they speak. So we're now going to have a roll call of disclosable pecuniary interests. So I'm going to ask members, they are reminded to disclose any pecuniary interest in any matters to be discussed, which is not included in the register of interest, and leave the meeting prior to the matter being discussed. I, as the Chair, have no interest to declare. I'm now going to read out the names of the committee members. Councillor Roy Allcroft. We'll come back to Roy. Councillor Gerald Dakin.
I've got no pecuniary interest to disclose.
Councillor Kate Halliday.
Yeah, no interest to declare. Thank you.
Thank you. Councillor Simon Harris.
Present, and I'm the director of a care home in Broseley, which receives Shropshire Council funding. So that I think should be noted.
Thank you. Councillor Tracy Huffer. Councillor Simon Jones.
Yeah, present, and I have no pecuniary interests.
Councillor Heather Kidd.
I'm present and I have no pecuniary interest.
Thank you. Councillor Paul Milner.
I'm also present and I also have no pecuniary interest to declare.
Councillor Mad Shinton.
I'm also present. I have no pecuniary interest, but I do have an attachment with health concern over the border in Wyre Forest.
Thank you, that's noted. Can I now ask the other participants who are taking part in the meeting confirm their presence? I've got David Voicey, Health Watch representative.
Yes, I'm here.
Thank you.
Thank
Councillor
you.
Dean Carroll, portfolio holder for Adult Social Care.
Present, Chair.
Thank you. Tanya Miles, Interim Director of Adult Social Care and Housing.
Good morning, I am present.
Thank you. Patricia Blackstock, Service Manager, Hospital and Reablement.
Good morning, I'm present, thank you.
Daniel Webb, Overview and Scrutiny Officer.
Good morning, Chair.
And Amanda Hollyoak, Committee Officer.
Yes, I am present, Karen, and I think also we may have Deborah Webster, Service Manager, Commissioning and Governance, present.
Oh yes, I do apologise, that's my fault. I did miss her off. She's on my list. Deborah Webster, Service Manager and Commissioning Governance.
Good morning, Councillor Calder. Yes, I'm present. Thank you.
Thank you, Deborah. Now we turn to the items on the agenda. Apologies. Apologies have been received from Councillor Roy Allcroft. Can I just go back and check on Tracy Huffer? Has she joined us? Heather, do you have anything from Tracy?
No, I don't, but if she's on Clee Hill, sometimes they have real problems with their broadband.
Okay, well, we'll when she comes in, we'll just ask her about pecuniary interest and what have you. Can the committee officer confirm if there are any other apologies?
No other apologies received, Chair.
Okay. Item 2, disclose the pecuniary interest, that has been taken, dealt with during the initial roll call. The minutes, item 3 is the minutes of the last meeting, and I'd like to move the minutes of the Health and Adult Social Care Overview and Scrutiny Committee meeting held on the 21st of September 2020 as circulated be signed as a correct record. Can I have a seconder, please?
I'll second that, Chairman.
Thank you very much. That was Councillor Madshinton. I will now accept these minutes as a true record unless anyone indicates differently. Thank you. That is now taken. Item 4 is public question time. There have been no public questions received at this moment. Item 5 is member question time. No member questions have been received. So we now go on to item 6, which is the Adult Social Care Winter Planning. Tanya Miles, Interim Director at Social Care and Housing, and Deborah Webster, Service Manager Commissioning and Governance, and Patricia Blackstock, Service Manager Hospital and Re-enablement, are here to speak to the report and answer any questions. Tanya, can I ask you to introduce the report now?
Good morning, committee. So I'm Tanya Miles, I'm Interim Director for Adult Social Care and Housing here at Shropshire Council. I'll just introduce the report and then my colleagues Deborah and Patricia will step us through some slides in terms of the report. So the Shropshire Council Adult Social Care Winter Plan sets out how the council, along with the voluntary sector and statutory partners, will work together to protect and support local residents, including those who are clinically vulnerable, providers and our workforce as far as reasonably as possible. The aim of the plan is to ensure that high quality, safe and timely care is provided to all those that need it, whilst protecting the people who rely on care, their carers and the care workforce from COVID-19. The challenge of managing the impacts of COVID-19 health and care system is at its busiest will require an effective, robust and coordinated effort to ensure that the system is able to meet the increased demand for services and provide high quality care and support. The guidance is clear that the first priority to councils, care providers and the NHS is to prevent infections into care homes and protect staff and residents. And whilst the winter plan focuses on care homes, here in Shropshire, we have tried to ensure that our priorities focus on the wider community and wider care settings. The plan covers the period from the 1st of October 2020 and will run up until the 31st of March 21 and sets out clear actions for preventing and controlling the spread of infections in care settings, collaboration across health and care services, technology and digital support, supporting people who receive social care, the care workforce and unpaid carers. Shropshire Council works really closely with its neighbourhood local authority, Telford and Wrekin County Council. We are partners in One Sustainability and Transformation Partnership, SDP, and we work alongside the CCG and the Shrewsbury and Telford Trust and Community Trust. Our SDP is strong and robust and we are working together effectively through the COVID-19 pandemic. Partner organisations are closely following guidelines and putting appropriate support in place. Now, the recommendation in this report to the committee is to consider, make comments and endorse Shropshire Council Adult Social Care Winter Plan 2021. I'm now going to ask Deb and Trish to give us a bit more detail amongst the plan, if that's okay.
Thank you.
Thank you.
Good morning to the committee. It's Deborah Webster here. I'm the Service Manager for Commissioning and Governance with Adult Social Care. I wonder, Amanda, if you'd mind popping the slides up.
Hello, Deb. I'm just going to see if I have received the slides. I won't be a moment. Hadn't about 10 minutes ago.
Let me share them. Here we go. Can I confirm you've got the slides?
That's good. Yeah.
Lovely. I'll take control, Deb. I've got the slides we'll take from slide 7.
Okay, brilliant. Thanks very much. So I'm just going to talk through some of the themes from the winter plan. The first thing that I want to talk a little bit about is the overarching work within the health and care system. This is the part of the plan that focuses on broader issues like the guidance, the planning, the communication, our partnerships and our service planning as we head towards winter. So we're focusing particularly on co-production, including care providers in our planning. We're focusing as well on the community and primary care at home and in care homes to avoid hospital transmission, and what action we take to treat and investigate cases. We are looking at care home visiting, particularly at addressing inequalities, implementing and promoting the guidance that comes out and helping providers to understand it, and working through the enhanced health in care homes framework. And we're also focusing on having open day services and respite services. So I'd like to focus particularly on the visiting. If you might move to the next slide, Tanya. Thank you. So care home visiting is a particular issue, and it's something that we talk about a lot. Shropshire Council are working with our partners to look for a very balanced approach to care home visiting, understanding that family contact is really important, and recognising that we need to balance the risk of COVID with the importance of having visitors and seeing people and loved ones for the well-being of residents and their families. And part of our approach to care home visiting is recognising that care home managers and owners are best placed to understand risks in their homes and the individuals that they care for. We review guidance regularly, and we're just about to review it again. It was the last version came out at the end of October, so we review that continuously to make sure that we're getting that balance right and responding to issues that come up around visiting. There has obviously, as you're aware, been a rapid rise in our community, and part of our approach is not recommending visits without barriers, but we are working with our providers to make sure that there are really good alternate ways that people can have visits. One lovely example I just wanted to share with you was care homes having visiting pods in the garden. They're like glamping pods, if you like, which have a perspex barrier, but they've also got a really good intercom system, so people can talk to each other really well and clearly and see each other really and be quite close to each other, so that they can have those very important visits without any level of risk. It's important just to say that that's not a directive. We haven't said that there's no visiting as a directive, and it is very much a risk-based, place-based approach. So moving on to day opportunities, day services remain open. We are using a range of ways to support people so that they can come together safely or be supported with different ideas at home. So there are fewer people in our centres at the moment that are able to come, so we're making sure that we are supporting people in their communities and from their homes and through digital means. Some particularly nice examples of the happy boxes that day staff have been sending to people at the start of lockdown, which have been a big success, and the good things to do at home, which are resource boxes, allow people to stay in touch with each other and work together from their respective homes on different activities, which has been really positive. With our supported living schemes, because people are living in their own homes, a lot of them do tend the day services as well. But in addition, we've been supporting those people who live in tenancies to have additional technology to sort of ease their tensions and anxieties. So these are activities based. We're using these Omni projectors, which are interactive floor and table projectors. So the different providers, there are 5 of them, each have one of those that they can use in different homes and allow people to have those different experiences, lots of games and interactive and sensory applications that those offer as well. So those are just some examples from some of the work that we're doing around theme A. So on theme B, we're looking at preventing and controlling the spread of infection in the care settings. That particularly focuses on PPE, on managing staff movement, on ensuring that people have their seasonal flu vaccinations, and on making sure that our testing is as robust as it possibly can be. If you'd mind moving on to the next one. Thank you. So number of different testing options, which I know you're aware of, we've spoken about before, but it's worth just mentioning that we, as well as the standard testing processes, we have mobile testing units which can be deployed where there needed to be local testing sites where we can take testing to people during an outbreak. The postal testing kits, which are available to all the residents of Shropshire, and obviously the robust national testing that you know about, and in addition we've been as of last week we've got fortnightly testing for our domiciliary care providers as well, on top of the national approach. We've taken that additional more robust local approach. So just on the PPE, the personal protective equipment, we've got a team running our PPE systems, which are ordering and managing stocks and making sure that people have got access and understand what they need to do to get access. Currently, all of our providers can access the national portal, but they also have the Shropshire Emergency Supply Chain if they have any issues. All of our providers at the moment are reporting a positive position on PPE, but in addition to that, we're looking at the ongoing support around PPE and testing and making sure that complacency doesn't set in, fatigue doesn't set in, and that we are reiterating those messages and the absolute vital importance of testing and PPE, as well as the staff movement we've spoken about on this theme. So I'm going to pass you on to my colleague Trish, who's going to talk to you a little bit more about theme C.
Thank you very much. Good morning, committee members. Patricia Blackstock here, Service Manager for Hospital and Reablement Services. So, theme C of the winter plan looks at collaboration across health and care settings. So it looks at safe discharges, prevention of avoidable hospital admissions, and also social prescribing. Can I have the next slide, please? Can I have the next slide, please? Thank you. So Shropshire's Discharge to Assess Hub ensures that when a patient is ready to be discharged from hospital, they can safely be transferred without delay to an appropriate setting. Now, the hub is a multidisciplinary health and social care partnership who work together and ensure that all elements to support and facilitate a safe discharge are in place within a timely time frame, so that there are no delays in hospital. At the other spectrum, we have a CCG commissioned admission avoidance service, which operates a strong partnership between the council and Shropshire Community Health Trust. Now, this admission avoidance service is also complemented by West Midlands Ambulance Service,
Patricia, you've gone on mute.
She's turned herself off.
I'm very sorry. Next slide, please. Can I have the next slide, please? Can everyone hear me?
We've got acute hospital admission avoidance as the slide on screen.
Okay, so I discussed that in terms of the acute admission avoidance. This is the jointly commissioned service or partnership between adult social care and Shropcom, and that supports people to be maintained in their own homes rather being admitted to hospital. Okay, next slide. Thank you. So theme D supports people who receive social care, the workforce and carers. Our winter plan sets out various elements of this, the themes being supporting the well-being of the council's workforce capacity, staff training and social work and professional leadership. Also supporting independence and quality of life, such as the use of direct payments, support for unpaid carers, and support to those shielding and clinically vulnerable groups. And in addition to that, it looks at the legislative elements as set out in the Care Act easement. So for adult social care, an essential visit guide was developed. This is reviewed regularly and updated to support the community social work teams. This sets out guidelines for practitioners who must consider prior to each visit whether the planned visit is essential or whether the work can be undertaken in different ways. It stresses flexible responses must always be considered to explore options to meet need. For each team, all assessments and reassessments are RAG rated so that we ensure that the highest level of need is met first, and also practitioners continue to work from home where appropriate. WIPS, which is the Wellbeing and Independent Partnership Shropshire, consists of 5 voluntary and community organisations. They undertake an initial contact with an individual to support people's well-being, and then they may well offer follow-up support that is identified from the initial contact. This support may be shopping, delivery, connection with local groups, medication collection, and telephone befriending. The organisations involved: Age UK, Shropshire, Telford and Wrekin, Shropshire Rural Community Charity, Royal Voluntary Service, Oswestry Community Action and Mayfair Community Centre, Church Stretton. There's also support to staff and also members of the public for mental health and well-being via telephone line and also a website. Next slide, please. Informal carers are supported in a number of ways. So the Carers Pass advises that carers are caring for a vulnerable person in the community who relies on their support. We have comprehensive information and advice to support carers in their caring responsibilities. And we've also commissioned specialist providers to support people or carers of people with a learning disability. Next slide, please. We have free online support for carers, including email courses, virtual cuppers, private Facebook communities, and also telephone support via Crossroads Together, which is accessible weekdays 9 till 5. Next slide, please. Next slide, please. Okay, I'll talk to it anyway. So our housing team also works closely with the hospital team to support people with housing needs to enable them to be safely discharged from hospital. In addition to that, our housing team activates a cold weather provision which provides accommodation for all rough sleepers in the county between November and March each year. Okay, I'll then pass you on to my colleague Deborah, who's looking at theme E, which is supporting the system.
Thanks, Trish. So the theme around supporting the system is making sure that everything, all of the support is coordinated, wrapped around where it needs to be. So it's talking about the general support of the system as a whole. It's talking about the market and provider sustainability, our CQC support, the emergency support framework and sharing best practice, and the local, regional and national oversight and support. So we have a system-wide care market action plan. So this is just the plan is quite comprehensive, but this is sort of a plan on a page, if you like. So this looks at the whole of the governance and oversight, you know, what our whole system approach is, you know, as we mentioned, PPE, risk management, those kinds of things. It's about the financial support as well that we give the market, the payments we've given to support increased cost, the payments in advance, paying invoices within 5 days, the IPC grant, all of the things that we are putting in place and facilitating to make sure that the market is as robust as it can be. The PPE we've spoken about, but the infection prevention and control as well. We've got really good connections with the infection prevention and control team to make sure that we've got training support going in, that the care homes and care providers in the community understand the needs around testing and compliance and all of the guidance that they need to be aware of and share. Testing we've spoken about, but there's the communications and the workforce, supporting the workforce in terms of their well-being, making sure that people are redeployed where we need to, supporting the leadership and HR issues, and the multidisciplinary teams and enhanced health in care homes. And again, that emotional and psychological support for our care market as a whole. So the care market as a whole within Shropshire, looking at comparison across with the West Midlands, our homes are showing an 89% occupancy rating, which means that essentially there are more people in care homes than there would be across the West Midlands, which is a good sign around the robustness and the market not being as fragile as it perhaps is in other places. In comparison to average staff shortages across the region, from the data that the care homes put in to the national tracker, that's showing that on average about 9 staff short across the piece, whereas on average in other counties it's about 38. They're all reporting a positive status for PPE, and the majority of our care homes have confirmed that they are able to isolate people if they need to. And just a caveat to that, sometimes, I mean, actually our experience is that all of our care homes are able to isolate people, but sometimes they don't report that as regularly as they perhaps should be, but some of their priorities are to do with making sure that people are safe and supported well, rather than reporting. So we follow those up wherever there's a slight shortfall. So sorry, can I pass you back to Tanya to conclude?
Thanks, Deb and Trish. So hope members would agree it's a comprehensive plan that we've put together. Local authority every year contributes to the system-wide winter plan, so this is the first year we've actually been asked to put together our own version. So we'd now welcome some comments from committee, please, and any questions on the presentation and the paper. Thank you.
Can I, before we start, can I thank you all for, it is a very, very comprehensive report, and I think we look forward to asking questions to get a little bit more detail, if you like. And the first one, thank you for including the action plan on a page in your presentation, but could we have a little bit more detail, please? Can that be sent to us as soon as possible so that we can look at more detail of the action plan? You know, I think what's the saying, you know, all plans are good until they go into battle, or something along those terms. But so we would appreciate receiving a more detailed action plan. I think there are, can I just clarify? I'm going to ask a stupid question. I did ask it of colleagues, and they were as they said it's something that needed clarifying. In one of the slide, the pictures, little pictures that's in the report, it talks about 50% of population clinically vulnerable. Now, I'm assuming that you're talking about over 65s that are clinically vulnerable, not 65% of the population. But I just thought, as you know, colleagues also said, it's not absolutely clear. I thought I'd just ask the stupid question and get some clarity on that. I think I've got lots of people wanting to ask questions. I have lots myself, but I will take the committee's questions first. Tanya, can you just clarify that point that I raised?
Yes, I can. Thank you, Chair. So as I understand it from our Director of Public Health, it's all age, so it's not just your older adults that are clinically vulnerable. So it may be adults who are in their 40s and 50s that have got conditions that make that kind of put them in the category of clinically vulnerable.
Wow, that makes you know, so we've got a population of what, 300,000 roughly, give or take. That's quite a large number of our population, isn't it?
It is. Mm-hmm.
Okay, I'm going to go to, I've got Simon Harris and then followed by Kate Halliday.
Thank you, Chair. Deborah, just one thing that's very concerning for my care home in Broseley. We have an extreme lockdown, and all the staff have, together with Shropshire Council support, have absolutely been tremendous. The support they've got and the welcome in their words that they say for the Shropshire Council officers and support has been incredible. But the question I have to ask is about visiting. There's been various rants and various pieces of paper being distributed lately over visiting the care homes. And although you state it's possible, can we confirm that it's down to the management of the care homes with the advice from Shropshire Council and not central government that is controlling this?
Thanks, Councillor Harris. Yeah, I can absolutely answer that. So our guidance for care homes it is very much based on a risk-based approach for the manager, because the manager is closest to the risks and understands best what those risks are. And yes, we will give absolutely all of the support that we can, as you referred to the support that the care homes are getting from the welfare officers. So they're getting regular calls from the team that's dedicated to making calls to all the care homes every week, just to make sure that they've got those contacts and any support needs that they have. But the risks that we refer to in the guidance have to be assessed on a local basis. We can't make a blanket, you can't have visitors kind of approach, because that's not the right balance. It's not the approach that we've wanted to take. We want to support people's well-being as much as infection prevention and control. So it's a balance to be made, and we give lots of advice around making those risk assessments and lots of suggestions around how visits can happen safely.
Thank you. That answers my question very well. Thank you.
Thank you.
Can I just ask a supplementary question to that whilst we're on this? Visiting is one thing. I think end-of-life care is another, and the ability for relatives to be with their loved ones at the end of life has been one of the most distressing areas that people have had to contend with. Has there been any additional provision for relatives to be with their loved ones at the end of life?
Thank you. Yes, there absolutely has. Yeah, there is an exceptions process where we obviously would understand that if somebody is towards the end of their life, limited or protected visits, it's a different situation. So the care homes are able to allow families to visit for longer periods of time during end of life, obviously to have face-to-face visits. They just make sure that they've got as much in terms of protection for other people within the home as possible. But absolutely, those visits need to take place, because we don't want to cause that level of distress by making arbitrary rules that would seriously impact people's well-being and cause them great distress.
That's very reassuring, thank you, especially in light of some of the reporting that we've seen over the last few days of people being arrested trying to take their elderly relatives out of care homes because they don't believe that they're going to be able to visit them or comfort them or care for them. So thank you. I've got Kate Halliday next.
Thank you, Chair. Yeah, I was interested and pleased to see discussion about support for homeless population in Shropshire, and I was just wondering if you could tell us a little bit more. I mean, there was a really fantastic effort during the last lockdown, but I was just interested to hear a bit more detail about what's being provided.
Thanks, Kate. So you'll all be aware of the Prince Rupert work that we've been doing here in Shropshire, and that work will continue not just only at Prince Rupert, but in other settings as well. During an average winter, a normal winter, we would put provisions in place to ensure that anybody who is rough sleeping has a place to go, a dry bed and a roof over their heads. And we know all of our rough sleepers well, and we're working with them to develop plans to ensure that they've got a bed and a roof, certainly over the winter. There's something called cold weather provision, which the government supports councils with, to make sure that every council's got provisions in place. But as you're all aware, during the first round of COVID, we worked really closely with local providers to support our individuals off the streets. So I can assure committee that that's a daily piece of work that is going on. And predominantly it's with the providers that you're all aware of here in the county of Shropshire. We've also got some other ideas, because we find from our rough sleeper communities that they prefer to be in the location of Shrewsbury mainly, because that's where their network is. But we absolutely are committed to ensure that our rough sleepers are offered and supported a bed and a roof over their heads.
Thank you.
Can I ask another supplementary question along those lines? This is great because it's picking up on all the questions that I wanted to ask. What other services do adult social care provide for our homeless and vulnerable community in terms of mental health support? Hello? Have I frozen?
No, Tanya, I think you might be muted.
Sorry, I couldn't get off the mute button. I do apologise. And then I think I did freeze for a couple of minutes.
Into some sort of limbo.
So as committee know, we've got an established community mental health team here in Shropshire, and we work very closely with the Midlands Partnership Group. Trish referred to the Wellbeing and Independence Partnership, of which the council has funded for this winter, because we're acutely aware that going into this winter and this round of COVID, for some individuals who are isolated and who are lonely are going to really struggle. So through the WIPS contract, individuals will be receiving a weekly conversation, a touch point to kind of check in on how people are feeling, how people are. It's not just about the basics of getting medication in and getting food supplies in and walking the dog. It's about ensuring that people's well-being and mental health is also being looked after, because it's really lonely if you're living by yourself and you're not part of a support bubble for various reasons, and then having that weekly contact with somebody is really, really important.
Thank you, Tanya. I still don't quite see how that's going to work with our rough sleepers. I can see how that would work with our, single people living in isolation and, and what have you. But I don't know how does that work with our rough sleepers? I don't know if I missed something there.
Sorry, I wasn't talking about rough sleepers. In terms of rough sleepers,
no, my question was specifically what mental health support is there that adult social care provides for rough sleepers, whether that's or substance misuse support.
Thank you, Chair. So we work very closely with ARC, which is a voluntary group in Shrewsbury, and again they provide that kind of face-to-face contact, that daily support. As well as we've got a very good relationship with the Riverside Medical Practice, and they provide some support to individuals too. And we also, through the Riverside practice, have mental health practitioners who work alongside that team with our rough sleepers.
Thank you. Thank you very much for that, Tanya. Can I go to Heather Kidd now?
Thank you. Good far-reaching report, so thank you for that. I'm quite interested always in the detail of some of this, and I would be really interested in looking at the capacity in local areas, because capacity within care homes or for care workers does vary greatly across the county. So although it was running at, what was it, 89%, I'm always interested to see how that will differ. So if we could have some of that detail, because if you've got somebody who's got to go into a care home to be discharged from hospital and so on, for them to be put into somewhere like Market Drayton when they've come from, I don't know, Bishop's Castle or Newcastle on Clun, is difficult for relatives and for them, even when visiting is quite severely restricted. So I really would appreciate a bit more detail on that. I'm also interested in the capacity of the split for mental health issues and not rough sleepers. I know that actually we find placements for people who are mentally ill quite difficult, and Tanya will know I have one at the present time. And when somebody cannot be admitted now to Redwoods, because they've already been there, they haven't improved, trying to find a placement for those is like pulling teeth, especially in some of those establishments which then get COVID. So I wondered what the council were going to do to increase that capacity so that we can take somebody out of the community if they really cannot stay there, but are not bad enough, or that Redwoods haven't got the capacity to take. And I think that's a significant issue, because COVID is actually making a lot of this much more difficult in communities, and I appreciate greatly the sort of support that we put into people to stop them from getting that bad, but it still happens. So some detail around that and how we might increase capacity. And on top of that, I know there's an issue around respite, because if we're going to look after our informal carers and our carers, then the ability for people to have respite for their loved ones and for other members of the community is a fundamental, and I don't think we touched on that respite anywhere there. So all of those things, I'm sorry there's so much, but actually those are the things that really affect people on the ground, and I'd be grateful for some detail. Thank you.
If I could pick up that question, Councillor Kidd, thank you for that. So just in regards to the broader issues around capacity in different areas of the market, that's something we've actually been doing quite a lot of work on at the minute, looking at what capacity is available across care homes and in different areas. So as it stands at the minute, that we do have good capacity right across the market, and in all sorts of different areas. One good example of that was actually we've just advertised for some additional winter pressure beds. And whereas in some preceding years we've had difficulty getting a good spread of winter pressure beds across the county, this year we've actually managed to get a good spread right across all areas, and also a combination of nursing and nursing EMI, which has actually been really helpful to have all of those options in different areas. So I think we're actually seeing a really good position around that capacity at the minute, accepting that capacity changes continuously. So that's something that we need to monitor continuously. I do understand that. In regards the specialist kinds of services, it's actually something we've been talking to a couple of providers about, who are looking at diversifying. And whilst there are lots of challenges for the market at the moment, there are some good opportunities as well, and times for them to sort of look at and say, well, maybe there are different kinds of services, and to have that really good dialogue with us about what services we're short of. And your point around sort of more complex individuals, mental health, that sort of thing is well made, because that's one of the things that we're looking at. In regards respite at the minute is particularly challenging around the 14 days isolation when somebody's admitted into a care home, because if you're having some respite and perhaps giving your family a little bit of time as well, going into a care home and then being isolated for those 14 days is not necessarily the holiday that you were looking for. So we're looking at different options around respite at the minute. We were anyway, because I think it was something we were looking to have more flexibility and more opportunities and options for people around respite through things like direct payments and that sort of thing. So one of the solutions that we've come up with recently is actually using a holiday lodge and putting in domiciliary care package, so that it's actually supporting the individual in a small holiday setting. It's supporting our businesses, in holiday businesses who are not necessarily getting the kind of bookings they normally would, and it's also supporting our domiciliary care market. So we are coming up with hopefully some creative solutions around that particular challenge.
Heather.
If we could just have some of the detail around that capacity, it's really good news. It's just that I would just like to be able to see, just at the moment, and I know it will change, some of the detail about where the capacity actually is at the moment, how this is all working together, and what happens about respite. The mental health stuff is huge, but just to see, we've got a baseline at the moment, and see how that progresses, so that when we have the next meeting, we have some sort of idea about those pressures, how they've been picked up and so on, because that's what we need to do as a scrutiny committee, really.
Yeah, I do understand that. We're looking at quite a lot of information around demand and capacity, and looking at market and the risks around the market as well.
I'm glad you brought that up.
We can share that information. That's not a problem. We've got the information that we can split out north, south and central. And you're absolutely right, Heather. It'll be good for future committee meetings to have that data more visible. Also, we'll happily pick that up. In terms of the mental health, I think we've agreed to have it as a standing agenda item for January committee in terms of mental health. And so I would suggest that we add this into that agenda as well, in terms of capacity and providers in Shropshire.
Can I just say, I'm glad you brought up the modelling being done around the fragility of our care homes, and that whilst at the moment we're saying, oh, it's great that we have this additional capacity within the system, that also is an indicator that actually the care homes themselves are not getting the people in that they would expect in their business model to be viable and sustainable. I know for a fact that in my division, a nursing home has closed down. It was part of a larger group, and they took the decision to close, and it's quite a large nursing home. They took the decision to close the nursing home to allow the others to remain viable. So I do think that at this moment in time, in relation to a winter plan, to have that capacity, I do think we need to be looking very, very closely about the viability of the care homes going forward into the future once we're out of COVID.
I completely agree, and just on that, I'm sure Deb will come in a bit more detail, but we are working with our providers around how we can support them to manage COVID, but also life after COVID, in terms of either to do some things differently.
I think it's very interesting, isn't it, how people's are now very reluctant, and I'm just speaking very generally and without no in-depth knowledge, but I would imagine that people would now be more reluctant to allow their loved one to go into a nursing home. They would want to actually keep them at home or in a community setting, more so than because of the restrictions and what have you, no matter the work that we're doing. And I thank you, you're being very, very proactive in that. There is still this perception there that, I feel that about putting loved ones into a nursing home setting, so to speak. I've got Heather, Madge Shinton has a few questions to ask. Thank you.
Thank you, Chair. My question really is about the information that goes with the patient when they're transferred out of the acute sector into a community hospital, or indeed into domiciliary care or the care homes, and that's the quality of the clinical information that follows them. I was deeply concerned with a case in my own area where the patient was transferred from the acute to one of the community hospitals, and didn't seem to know about a long, complicated clinical history for this patient. And I was told that there's some sort of telephone conversation that goes on between the acute sector and the community hospital about the patient. For me, that smacked at something highly dangerous. Could somebody update me on where we are with that? And how do we monitor the living carer sector? Those two questions. Thank you, Chair.
Thank you, Councillor Shinton. Trish Blackstock here, Service Manager for the hospital team. Can I take the first element in relation to the information following patients in hospital? Yeah, we have, in terms of individuals discharged, patients are usually discharged following confirmation from the consultant, and they have a discharge letter that follows them to the next setting. So that's what should happen. We are aware that there are instances where there are challenges in terms of the quality of information that is transferred in relation to the patient discharge, and we have set up processes in place to monitor that as part of the discharge hub. So we're doing a piece of work around that to ensure that in terms of facilitating a discharge, that the best and most accessible information supports that discharge, and if there are areas of concern, that we have got a process in place where we can actually feed that back to the hub and actually sort of focus on that and do some work around making sure that the work is accurate. So we have set up a task and finish group that is in place to look at that very issue that you've raised, Councillor Shinton.
Madge, did you want to come back? You're on mute, Madge. Madge, you're on mute.
Sorry, Chairman, I thought I'd left my mic open. It's just as well I don't. Just to say that you mentioned hub. I don't understand what you mean by hub in this context. Could you just explore that for me a bit, please?
Sorry, of course. So when an individual, a patient is in hospital, there is a lot of work that is undertaken as soon as they go into hospital to identify where they will be discharged to. So that could either be a home-based setting with support, or it may be that they need another bed-based provision. So that could be a community hospital or one of the social care beds. But that information should be identified in the doctor's discharge letter, which then goes to the next setting. Now, the hub is the group of professionals that are involved in identifying what that discharge destination should be, and also the support that should be put in place at that discharge destination. So it's a group of professionals, so it could be social care workers, so social workers, the health professionals, etc., that coordinate the information to ensure that we have the best possible information that the person that is then travelled with the patient to their discharge destination. But I do take your point. There are times when we've identified that the information is not quite what we wanted it to. So we have got processes in place to make sure that we can actually scrutinise that in more depth.
Thank you for that. If you've got a task and finish group on it, I'm happy that we shall have a report about that, because I am deeply concerned, not just for the patient, but they're the prime ones, of course, but also for the staff on the receiving end of where the patient is transferred to. I think it's very dangerous if they don't have a full report on the patient's clinical history. Yeah. Because there are a number of errors, minor errors, but have had quite disastrous results that from lack of knowledge.
Yeah. Can I just also mention as well that we have got a Health Watch survey that is currently in process. So that was a survey to look at patient outcomes in terms of the quality of support they received and their outcomes following discharge from hospital. So that was live, I think, until the end of October, and we're waiting for feedback on that. So that would also support the work that we're doing in terms of facilitating patient discharges and getting the best outcome for patients. So again, we look forward to feedback in the outcomes of that.
Thanks very much. The monitoring of the live-in carers, where are we with that? Thank you.
If I could pick that up, thank you, Councillor Shanton. Firstly, for people that perhaps not aware, we have a framework of live-in providers. That was a framework opportunity that was offered out to our current accredited domiciliary care providers. It wasn't bringing new providers into the county because we've got quite a lot of domiciliary care providers. It felt important that we used providers that we already had knowledge of and have some robust monitoring of. So that framework has been in place now for just over 12 months. Providers had to apply for and meet certain standards for getting into that framework so that they had evidence that they had experience of and could deliver living care in a really good quality manner. In addition to that, we've got monitoring officers who work with us who monitor our markets. We've got weekly calls, as mentioned, around COVID and supporting them, so they're all getting that kind of support as well as monitoring. And then we have the ongoing daily contacts with our brokerage team, that sort of thing. If there are issues, complaints or observations that are made, perhaps by families or professionals who are visiting individuals in receipt of care, then we take that up and we will challenge providers to look at whatever appropriate action that issue requires. So that's our general process. If there's anything specific around a particular provider, I'd welcome that information if you wanted to email it to me and we'd look into that specifically.
Thank you very much for that. Thank you, dear.
Can I just ask another follow-up question on the back of that? Trish, you mentioned the Task and Finish group that's looking into the challenges, if you like, around the transfer of patients between acute and community hospitals. Can I ask that, or just confirm, there's not a Task and Finish group that involves members, it is an officer-led Task and Finish group? And can I also ask, what is the remit of that Task and Finish group?
Are you on mute, Trish?
I'm very sorry. Sorry, I was talking away.
Okay. Can you start from the beginning? I'm sorry.
Yeah, certainly. So we're doing some joint work. So the local authorities and our health colleagues, we're actually doing a piece of work on the process really in terms of discharge, and particularly if things go wrong or if we're concerned, what processes we should follow if there are clinical incidents, issues where we need to escalate, so that we have an overall process to ensure patient safety, and we have the right processes to feed into, and also that we have processes to ensure that we learn lessons if things go wrong. So yeah, it's being done in partnership with our health and social care colleagues and both councils, so that's Shropshire and Telford and Wrekin, and we're doing that as part of the ongoing work in the discharge hub, so with our colleagues. So great piece of work to just make sure that we get things right for patients, and if there are issues that we need to look at, and if things do go wrong, we've actually got structures in place to address that and learn lessons from that.
So basically the scope of the Task and Finish group is to look at failures within the current process that we have at the moment. What's the time frame on it, the time scale for the Task and Finish?
It's ongoing at the moment, so it's something that I could feed back at the next meeting if that's okay.
Okay, thank you for that. I've got Kate Halliday on the list of speakers.
Oh, sorry, Chair, no, my question's actually been answered already.
Okay, thank you for that, Kate. Gerald Dakin.
Thank you, Chair. Quite a few questions that I wanted to ask has already been answered, but can I just say that when this paper was coming forward and it came quite late. I can understand why it came late, because of course when you started this paper, I suppose we hadn't got the new lockdown, but now that that's there, well, it includes that. Can I say I think this paper is very cleverly written. 48 pages is quite a long piece to read, but however, it would have been a lot more if we hadn't put the links in, and those links you could take one at a time afterwards, and they're very informative. What I was most impressed with is the fact that someone on first point of contact could actually, after a telephone call, use this thing to put a patient or a query, someone who's querying something into the right place at the right time, and I think that's an excellent idea. I think, as I said, the paper's very, very good. I was quite amazed at the PPE. I looked at there was a section on how to assess the PPE and things that need to be done. I didn't realise it was quite such an expensive process when we're dealing with somebody and you have to throw away every gown, every piece of equipment that you've worn to be thrown away. And I'm very pleased now that the government is actually paying for this rather than us, because I think it is quite an expensive process. When this was first written, as I say, I'm sure that the lockdown wasn't there. Is there any more about the lockdown to be added to this paper? And could we all have a copy of this paper? I'd like a printed copy of it. My equipment doesn't allow me to print out 48 pages, and I thought it would be very useful. I'd like to have a look at this at a later date so that I can refer to it if anybody refers things to me, so that I can find an answer for them fairly quickly. Thank you, Chair.
Thank you. Tanya, would you like to answer about, as I say, you didn't have a crystal ball, but I'm guessing that maybe you started to put together this plan, bearing in mind that there might be a second lockdown. Would you like to comment on that?
Yeah, thank you for that. And I guess this isn't the winter plan. It won't stay like this for the next few months. I guess what we would say as officers is that we're going to be regularly reviewing this on a fortnightly basis, and that we will need to update it as we move forward into this winter. Certainly when we were starting to write this plan, we wasn't expecting a full national lockdown that we've got, but I guess in some ways it hasn't come as a surprise either. So the plan was written with the view in mind that things will change very quickly, and that we will need to adapt, as we have done as a council, to the needs of our communities, our providers, and working very closely with our NHS colleagues. As I said at the start of the presentation, we usually contribute towards a system-wide winter plan. This is the first time as a council we've been asked to put together a standalone winter plan. And I'd like to commend colleagues for pulling this together in quite a short period of time. I think it was 3 weeks, of which one of those weeks was half-term week. So it is a very detailed plan. You're absolutely right, Gerald. But it's not a plan that will just be signed off and sit on a shelf either. It's a plan that will be a live document and will need to be regularly reviewed, and we'll need to update it. So I understand why you may want to print out a copy. I'm slightly nervous about suggesting we do that, because I think this plan will change as we move forward into this winter and adapt to this virus and pandemic.
Thank you for that. But even so, if it changes slightly, it's not going to change completely, and it is a useful guide to have. And I certainly would like a copy of that plan.
Gerald, I can I can get that for you. I have printing capability, and I'm a bit like you. I do like my paper. It's a terrible habit. I wonder if there's if it's an addiction, but I absorb information far better from paper than I do from a screen. But I'll make sure that you get a copy of it, albeit with the caveat that Tanya's put in that this is likely to change. It's a good reference point.
What I would like to just further add is that what sits behind this document is a RAG, a red, amber, green status. So for every action we have RAG rated.
Yeah.
So I will share that with members as well, just so you can see that it's not just a narrative plan.
Yeah.
I will say the point again, it's not a plan that would just sit on a shelf. You know, we've committed to reviewing this on a fortnightly basis and either, you know, making amendments or adding things to as we move through this winter.
Yeah, thank you, Tanya. I think that would have been very, very helpful to have seen that as a snapshot, if you like, of how you're moving through and addressing the actions and where you are in relation to each of the actions. And I think we would be, you know, we could take it as exactly what it is, a snapshot in time that will evolve and will change depending on the current situation within our communities. Gerald, has that answered all of your questions? I think it did. I've now got Paul Milner.
Yeah, thank you very much, Chair. I just got a couple of quick questions. The first question really is, are all the care homes all right for PPE? Have they got what they need? Have they got you know, the protective equipment, the cleaning fluids, and everything they need? And the second question really is, are residents of care homes receiving the essential treatment in hospitals that they need? Maybe it may be for cancer or other long-term conditions. Are they still receiving them? And then what is the procedure from bringing them back from hospital back into the care home? Thanks.
Thanks, Councillor Milner. It's Deborah Webster here. I'll pick up the question regarding PPE, if I may. So we have a process through which the care homes report on every 3 days their position on various things. So that'll be things like staffing, what kind of vacancies they've got, and PPE is one of them. So looking at it at the back end of last week on Friday, we were seeing a positive position on PPE from all of our care homes. It's something we monitor continuously, so the conversations that happen with the welfare officers who call the care homes, they check in with them as well, just in case the situation's changed or there's a particular type of PPE they're struggling with, just so that they can support them, make sure that they're getting access to the national portal for PPE we've spoken about, or to our emergency access PPE if they've got any issues at all. Cleaning products is an interesting one, actually, because we've had to give advice out about what cleaning products are good ones to use and what ones aren't. But the infection control fund money as well has supported the care homes with all sorts of different infection prevention measures too, so that we can make sure that they're funded for those bigger issues like you know, the pods we mentioned, for example, for visiting, that there is money there, or making sure that they're cohorting staff or preventing staff moving between care homes so that they can block book them. So there's lots of other things that sort of overlay those as well, just to make sure that we've got the best infection prevention control measures that we can. But yeah, there's challenging times for care homes, so they do need a lot of our support.
Okay, thanks.
Okay, thank you. Can I pick up the second part of the question? And that was about appointments for patients in care homes. So as part of the phase 3 plan, what the government stressed was that all NHS appointments should continue as part of the restoration, so that people should maintain their essential appointments and, you know, to maintain them in terms of their well-being. So the NHS is still open, and people obviously will go to hospital for their outpatients appointments, etc. If patients are admitted, then obviously there is the challenge in terms of isolation, etc. But people that are being discharged from hospital will be tested to confirm their COVID status, and then that directs the destination. So if there are, you know, issues around them being COVID positive, then we've identified destinations for those individuals to go to whilst that COVID status is stabilised, or they will go back to their care home. So there are a number of things in place, but the stress is that people should maintain their appointments.
Well, that's good news, because I'd hate to see a backdate or a backlog of especially essential appointments like chemotherapy or whatever it might be, and that's good to know that they're actually receiving the treatment that they need during this time. So thank you very much for that. Thank you.
Absolutely. Thank you.
Thank you, Paul. Heather Kidd.
Just coming back to the report, which is a huge report, I would really welcome the red, amber, green data, because that's part of the detail that actually I needed, although I've asked for specific data as well. Could we, when we see this report come back to us, see where it's changed? Because quite often it's very difficult to look at how a living document has actually lived and changed from the baseline. So the tracking on it, or the changes on it, if they're highlighted, will make a fundamental difference to us as a scrutiny committee, so that we can see how things have moved out there in the community and have moved within the council as well.
Absolutely, that's not a problem at all, Heather. And just to explain that the pace of change that we've had to work over the last couple of weeks, the RAG status wasn't ready to be circulated when I circulated the narrative on Tuesday, but I have signed it off over the weekend, so very happy to sign that off and send it out to colleagues today.
Thank you for that, Tanya. Kate, you've come back in.
Yes, thank you, Chair. I do have a question this time. My question was partially around the finances, actually, and obviously this is a huge amount of work with additional stresses on finances at the moment. So it was a general question about finances. I know you had highlighted it and how we're going to manage this programme financially. But tagged into that, I was also just interested to know whether additional finances have come down to the council regarding support for domestic violence, which I know was an issue during the last lockdown, and maybe just any feedback on support for domestic violence in general.
Good question. Thank you, Kate.
If I could just pick up the question around the general funding, if that'd be helpful. So one of the big pieces of funding that is currently happening, we're currently distributing the second round of, is the Infection Control Fund money, which goes out into the care sector. The initial one was allocated, 75% of it went to the care homes and the rest we had discretion over, so we used that for our community care provision. This round, the second round, we've 80% of it was allocated by the government to care homes and the domiciliary care community care market. So that's currently being distributed, and the discretionary area of that funding, the 20%, we're using to support people with direct payments, we support the voluntary sector, our shared lives, and we will have the second part of round 2, if that makes sense, come to us in December, and we're currently looking at how we can use that additional 20% in December's round of funding as well. But that's just the Infection Control Fund money. Of course, we did put some other money into the care sector, and the initial part, when we realised how challenged providers were, this is going back to April time, around the costs of PPE that have been mentioned, and that we actually put some other COVID funding out into the market, which was equivalent to 10% of their contract for 12 weeks at that point as well. So just over 11 million with this round of funding as well is going into the care market currently. So it's a significant influx of money into the market to help support those kinds of issues we've been talking about, those fragilities we've been talking about as well.
Thanks, Deb. The government has given money to both the council and to local NHS during the pandemic. So we've had additional money from NHS in terms of supporting people out of hospital safely. We've had additional money to support homelessness and our rough sleepers. You're absolutely right, Kate. We had some additional money to support women and men who are fleeing domestic violence, supporting our clinically vulnerable and supporting individuals who are socially isolated, direct support in terms of food supply, medication and other support. The council is monitoring our expenditure very, very carefully. It's not just in adult social care and housing, it's obviously across the wider council, including children's social care. And the government, is committed to supporting people well during this pandemic. So we're likely to get some additional money, we suspect, before Christmas, to continue to support, this really valuable work that we have been doing here in Shropshire.
Thank you. I guess it can't be an easy thing to manage because things are changing so quickly, and you're probably not always sure of when you're going to get additional money, etc. So it sounds like there's very close monitoring going on anyway. So thank you.
And just to add to that, if I may, it's not just about living through this next phase of the pandemic, but thinking about life after COVID. And we are hearing more references made to something called long COVID. That's people that have had COVID and are still quite poorly once they've got through that initial recovery of COVID. And in terms of the mental health aspect, we can't underestimate the impact on people during COVID. And we are uncertain what that might look like for a number of individuals here in Shropshire. But the council is monitoring that demand, that activity very closely with our health colleagues and with the voluntary sector, and we will adapt and change our services to meet the needs of individuals. But certainly through the LGA and through ADAS, we are making representation, and it's not just about funding to manage this winter and manage this round of the pandemic, but also we're going to need additional support to support people that have got long COVID and the mental health aspects and other complications. The NHS is very much open for business. That is a very clear message that we're all hearing right now from NHS colleagues. And the campaign about it's just, I think you've probably seen it on the TV, that if you've got a lump, don't just think it's just a lump, but to seek support from the NHS. And sadly, we saw through the first part of the pandemic that people didn't go to the NHS when they needed to. And it's a really important message that the NHS is open, and NHS is there to support people and to treat people. But as a council, we are working so closely with our partners in the NHS and the voluntary sector, so we truly understand what the current need is in our community and what the future need will be.
Thank you.
Thank you, Tanya. I'm glad you raised the mental health issue, because it is something I don't think we can underestimate the impact that, post-COVID, the pressures on our population in terms of mental health is going to be. And as I was reading the report, I was trying to pick out what role and how active had MPFT been in pulling this report together. I didn't get a feeling that I couldn't see active participation, if you like. That I could be completely wrong. So there's that. I'd just like to go over. So there's the mental health issue, the activity or participation by MPFT in pulling together this winter plan. And then I'd also like to talk about reporting, which is testing, which is mentioned in the report. And it says that there are gaps that have been that were mentioned in the report. And how are the gaps being addressed? So that's second. I'm going to give you one more as well, and that's around flu vaccination. How are we progressing with these? What have the challenges been? Is there any slack in the system? That's three, and then I'll take some other questions from other people.
So if I take the MPFT, and colleagues will no doubt jump in and help me with this one, but MPFT is a very close partner of ours. You know, when I talk about our health partners, it's not just about the Acute Trust, it's not just about the Community Health Trust. You know, MPFT is very much a close partner with us, and we have regular meetings. I think it was daily during the first round of the pandemic, working very closely with the local authority to ensure that we understand what the current need is and where the demand is. Trish, Deb, anything else you wanted to add in terms of MPFT?
Yeah, certainly in terms of one of the winter schemes, we work very, very closely with MPFT to ensure that we had specialist support for people with mental health concerns to enable them to be maintained outside of hospital and in the home. So we did actually bid, and I think that was approved, for specialist mental health nurse to support with our admission avoidance scheme, specifically to support people with mental health concerns where, you know, there's a threat that they may be admitted to hospital. So that has been really, really supportive, and they continue to work closely with us in terms of weekly meetings, again, to support admission avoidance.
So is that something, can you just give a little bit more flesh to that? Is that something like sort of a mental health professional that's mobile, that can go out to a patient or a resident who is in danger of being admitted into hospital? Are they mobile? Is it a physical face-to-face assessment, or is it a telephone? How does it actually work?
Yeah, it can be sort of all of those things as you've described. So the admission avoidance scheme is, as I mentioned earlier, a joint partnership between the local authority and Shropshire Community Trust, and that's to facilitate, to ensure that people are maintained in the community, so that there's a reduction in unnecessary hospital admissions. One of the things that we did identify was actually there was a need for that specialist dimension in terms of specialist advice for mental health. So we work closely with the mental health team, and they were able to ensure funding for a specialist mental health nurse that can do some of that advice, information, signposting, or indeed support via a visit to the individual to keep them out of hospital. So it's all wrapped up in a service. So whatever is needed to maintain that person in the community. So certainly in terms of the admission avoidance team, that does involve visits, it involves advice, information, anything that's required. So it could be support as well within the home.
Is that a 24/7 service, or is that just sort of office hours?
The admission avoidance service operates from, goodness me, 7 till 10, 7 days a week. But we also have support overnight as well in terms of care provision. So if that's required, we can offer care overnight. But the clinicians work 7 till 10. Okay,
thank you.
Could I just pick up the question about flu vaccines?
Yes, thank you.
Okay, so I mean, flu vaccine, obviously seasonal flu vaccines being widely offered, and you'll have seen various adverts on that. There's been a particular focus on ensuring as many people in care homes have had seasonal flu vaccines as is possible. The plan for that went through the usual process and through Silver Command, and GPs are prioritising care home residents. Community pharmacies can do free vaccines for care home staff as well, and there are various voucher schemes happening as well, but GPs are being supported with protected time to ensure that care home residents are prioritised around flu vaccines as well. So we are seeing good uptake. Been a couple of periods of time where shortages of the actual vaccine, but that seems to have sorted itself out now. So hopefully we are seeing that process working really well. And obviously there are going to be, whenever there is a COVID vaccine in the future, ongoing plans for all of that as well. So you know, which will be mobilised once something is confirmed as being ready and working.
But what were the gaps that were mentioned in the report? Were they just that there was a shortage of the vaccine in over one particular period of time, and has that now been resolved? I know we're talking about historical information in some respects here.
Yeah, no, that's quite right. There were some gaps in terms of vaccine supply. You know, some pharmacists had and GPs had more demand than others. So that's been sorted out now in terms of supply. There are still some national shortages, but there's an awful lot going on to resolve that. But I think in Shropshire we're seeing a much better position now that the supply seems to be flowing much better than it was earlier on as well. There were, when we first started looking at seasonal vaccine, there were a number of questions about whether or not that would be led by GPs, community pharmacies, whether or not we would have the facilities to go out and just vaccinate everybody. So that's been resolved now as well, with the GPs focusing on residents and the community pharmacies focusing in the main on the carers. So I think those initial issues I think have in the main been resolved. That said, vaccinating tens of thousands of people is always going to be a challenge.
And I think it's only going to the challenge is going to increase, isn't it, with whenever there is a COVID vaccine, because my understanding is that it's in two parts, 28 days between. So that is going to also be a great challenge, another challenge for our GPs.
That is right, yeah. I think there will be additional support. Certainly our colleagues in the NHS are looking to recruit additional staff and that to support that, because that is actually just an enormous undertaking.
Yeah. Absolutely. And then can we just go on to the testing, please? You know, again, I'm sorry, I've got my questions muddled up, but actually they're quite pertinent to either of these subjects in terms of gaps mentioned in the report, and how are the gaps being addressed?
So with testing, I think the gap that we were most concerned about going back some weeks now was regular testing within domiciliary care, because whereas the care home testing had a big focus, rightly so, because there's the most vulnerable people in our communities, and that national process was set up some time ago. That had its hiccups as well. The national system did have some hiccups in terms of getting testing kits delivered and then couriered back in a timely way. So we're in a much better position with that now, with care homes have all got staff within them who are trained to test themselves, so that the weekly testing of staff can happen and the 28-day testing of residents can happen. Our push after that was that we wanted more testing for domiciliary care and community care staff. That has always been there, but it's been on a as and when kind of basis, not the regular testing that we've been pushing for. So as of last week, we'd made that local decision, and our domiciliary care providers were informed last week that fortnightly testing be available for domiciliary care frontline workers as well. So it just adds another layer of protection and certainty for you know, carers in our community.
Can I just ask one more question on testing? What's the criteria for a request for a postal test, a test through the post, or for attending a local testing centre? Is there a criteria for it?
There are options around both of those. I mean, if somebody is symptomatic, postal testing is not necessarily recommended because it's slower to post a kit out, do the test, post it back again. So I think if somebody's symptomatic in general, it's a faster test that's going to be recommended there, as in an in-person.
And what's the take-up of that? What's the take-up?
On the postal testing, I'm not sure actually, but I can get that information for you. But I mean, in terms of numbers of testing, I'll get more up-to-date figures, but we were in the very high tens of thousands as of, apologies, I haven't got the current figures. I was on leave last week, but I can certainly get those and send them through to you.
And are we able to meet the demand for local testing?
So if I come in there,
sorry, go on, yeah.
So the government side is really clear about the criteria and about who can have a test. We were reporting locally last week that we had capacity in our test centres around Shropshire. So if people have got symptoms and do need a test, it's really important to book a test. But certainly, you know, it's a much quicker, slicker system now, and there is capacity within the Shropshire system for tests.
Excellent, thank you. Simon Jones.
Sorry, thank you. Thank you, Karen. It was first of all, I was just going to thank you for the question about MPFT, because I'm aware, obviously, of the amount of collaboration there is between MPFT and Shropshire. But it was interesting because, as I say, there hadn't really been any mention of MPFT in the report. My question actually was really about the finance, and that was alcohol and substance misuse. Obviously, that, I mean, is dramatically risen, alcohol and substance misuse during lockdown. And it was really just to see, was there additional funding coming for that? And then the other question was about MPFT. Presumably MPFT is involved with the Shropshire Discharge Hub as well. I just wanted to know that. Thank you.
Hi Simon, it's Tanya Miles here. I'll need to check if that's okay in terms of did we get additional money in for alcohol and drug related issues. So I'll find that out and come back to members if I may. Thank you with that response. And in terms of MPFT and the discharge process, Trish, do you want to pick up that response, please?
Sorry, could you repeat that element of the question, please? Sorry.
Yeah, it was just really with regards to the Shropshire Discharge Hub that you described. Is MPFT involved in that as well?
The Discharge Hub mainly focuses on the acute and community hospitals. However, we do have some contacts with them. So, for instance, if there's an individual that requires a bed within mental health services, then we would actually liaise with them. So yes, there would be collaboration.
Thank you.
Thank you. Can I just cover one other area and section of the report, and that's around the training, the webinar sessions that you've put in place. Prior to that in the report, you talk about you've got, and this I know is a big round figure and it covers the whole sector. You talk about 13,500 people employed within the care sector. And then I just want to then go on to the training that you're putting in place. And you talk about 718 attendances, and you've got more webinars planned, and you've got 539 places booked and on one course, and then 588 places booked on another. And I know that this has been brought up in the past by Councillor Mag Shinton, and that is the training of not just our workers in the care homes, but the training of our workers in domiciliary care. And I wonder, can you give me a breakdown? I'm assuming, and again I could be wrong, that the majority of those people that have taken up on the training are people who are working in care homes. And how are you able to get this this level of training, or are you trying to get this level of training out to people who are employed as domiciliary carers?
Thank you, Chair. Yeah, I'll pick that question up if I may. It's Deborah Webster here. So the training figures that are there are sort of part of the picture, because we work with Shropshire Partners in Care, who also delivered training as well. Training for the most part, due to COVID, has gone online. So you know, it's been quite a big shift in terms of making sure that mandatory training is still delivered and that they can all get to it. So the focus is on care homes and on domiciliary care. So we're looking particularly at the essential and mandatory training, things like first aid and, you know, those kinds of things that we would expect every single carer to have as part of their induction process. You know, safe moving and handling of people as well. And so it would be, some of it would be induction training, some of it would be refresher training, because we require them to be refreshed. In terms of monitoring how that happens, it's part of the accreditation process, is part of the picture, but it's also part of our ongoing monitoring, so that we're making sure that providers are complying with the mandatory training requirements that are in the contract, because it's actually standard contract terms and conditions that they have to meet those requirements, and that's across the board, whether it's community care, domiciliary care, care homes, that those basic standards of training are in place. We do occasionally come across situations where somebody hasn't had training, and then a provider will be held to account on that. But in the main, we've actually had really good uptake. They're not obliged to take training from our joint training service or from SPIC, although the majority of providers are members of SPIC and do use our joint training process, because it costs them less for very, very good training, but they can take it from other training providers as well, and we would look at the quality of that when we monitor those services.
So is there an accreditation to the training services that maybe are taken up by some of the providers, that not necessarily being yourselves or SPIC? Are the other training providers accredited, and how do they demonstrate that their staff have been trained, if not with you?
Yes, so some training courses do have to be accredited, things like first aid and manual handling, the mandatory training. Yes, they would have to be accredited, and providers are obliged under the terms of the contract to ensure that the training that they purchase or in fact deliver themselves, because some of them have their own qualified trainers in-house, especially some of the bigger companies. But yeah, we would look at the quality of that when we monitor them as well. So as well as it being, you know, certified and accredited training, we would have those conversations as well. Monitoring officers will even talk to carers just to make sure that their understanding of training is what it should be, because we understand that sometimes there's a gap between learning something and, you know, making sure that you've retained it.
So I'm just going back to my original question about what percentage of those people that have taken up the training are from the domiciliary care, or are the majority from, you won't have, I don't think you'll have that information to hand, but I would be interested to see what sort of breakdown there is in terms of who has taken up what training. I've got one more question on my list, but I'm going to, Madge Shinton has got another question, so I'll go to Madge next.
Thank you, Chair. I'd be grateful if you could give me information about what other training facilities there are out there other than us or SPIC. I am deeply concerned that we send, and they're often quite young people in the domiciliary care, and that's where I'm looking at particularly at the moment, who perhaps haven't got much in the way of life's experiences either when they go into an individual's home. And I am very, very concerned about elements of that. So could you give me information of whoever else is providing training and the content of that training? Thank you.
It's something we'd have to have a chat to the market about, and just if you wanted a list of training providers, so a lot of them have got their own in-house trainers as well. But things like manual handling and first aid have got standard items that they have to go through. So but yeah, I mean, it's perhaps we could have a little bit more of a chat about what sort of level of information you want, because we could survey the market around that, but it's in general terms, I can certainly get quite quickly for you lists of what mandatory training has content is required.
That would be really helpful. I mean, the first aid and the how to handle patients. Yes, you know, we have one or two social providers that run that, and there's a certificate at the end, particularly the first aid, etc. It's the wider thing that concerns me with, as I say, some of these often very young, going into individuals' homes, and their life experiences aren't alerting them to anything. And it's that element of training that surely somebody must have picked up, and that's the bit that interests me. Thank you.
Thank you for that. I've just got a question around the community teams, or one or two questions actually, in terms of, sorry, my dog's pestering me, in terms of how many people are they able to support, and do they have enough staff? Do they anticipate needing any more? I mean, these are all members of staff who've been redeployed out of their day-to-day jobs. So can we have just a little bit more information about them? And one of the questions is, how do these relate to commissioned with wellbeing and independence partnerships? What's their working relationship with those? I'm so sorry, my dog.
Sorry, Karen, just so I'm clear about the question, you don't mean the community social work teams, do you? You mean the community reassurance team? Is that who you're referring to?
Yes, that's the one. I'm sorry, my dog's got a collar on and he's scratching like hell, so there it goes again.
So yeah, the community reassurance team is resourced by colleagues in the council who have been redeployed for various reasons. They've been in situ through the first wave of the pandemic. Some of that was stepped down during the summer, but we have stepped it all back up again across the county of Shropshire for now and over the winter. In terms of the Wellbeing Independence Partnership, Shropshire, as we said earlier, it consists of those 5 voluntary and community organisations. They've been working very, very closely with the CRT. And this is not a crisis response service. It's a service that, you know, that we've commissioned to help vulnerable people maintain their physical and emotional well-being through the winter. It's a free service to people, and it is to support people over the winter months up until the end of March. The service is an enhancement to the current wellbeing independence service that we do currently commission. In terms of what the service will do, so they will be supporting people with their shopping and delivery. So I guess in terms of the relationship between CRT, the CRT workers might identify somebody who is in need of shopping and getting medication. So they would make that direct referral to WIPs. So shopping and delivery, connecting people to local support groups, delivering hot meals if required, collecting and delivering medication, and that really important bit around telephone companionship for isolated and lonely people, and wellbeing home visits and follow-up support if required. So the really important relationship between that community reassurance team and this service that I've just talked about.
How many people roughly have they been served? Are they supporting, or are they able to support?
Oh gosh, I haven't got that figure to hand, Chair, but I can certainly find out and get that figure. That's a detail that I don't have in front of me, I'm afraid.
Thank you. Well, I've not got. Oh no, I've not got any.
Hello, David here. I did put one in, typed it in. I don't know what happened to it.
The people. So I think I'll just. This is David Boise. He's our Health Watch representative. Go ahead.
Go ahead. Right. Actually, you've answered quite a bit yourself, Karen, the question you asked about testing. I'm also very concerned about the other half of it, the tracing. This has been very disappointing, and there could be people wandering around who are actually affected with COVID. Also, I understand from reading the papers that many of the checks being made are numerous to the same person on the same day and putting them off. So there's a great possibility that many people are not going into isolation, or for the length of the isolation they should be, because of the poor contact arrangements. Can I be told what control is there to make sure in Shropshire we are making sure tracing is done effectively?
Thank you, David.
So a lot of the tracing, as you know, is done by the national team, and there's been a fair bit in the press about that. In terms of our local public health team, they do their own track and trace, and they try and make contact with the people that have been identified. It is difficult, if I'm honest. Some individuals don't pick up the phone. Some individuals at times are not very helpful in giving the information over. That enables us to do that track and tracing and due diligence properly. It is currently under review, as you know, nationally. We do have a team here in public health that do that as best they can, but it does rely on that information coming through to them and from individuals, and for individuals to respond and to take the clear advice from public health.
David, has that answered?
As best as
question.
Yeah, you know, it's to me, it's still a concerning area that needs a lot of looking at to try and encourage people to respond properly. Thank you.
If our Director of Public Health was on the call, the clear advice is that we need to follow government guidance, and if we are displaying symptoms, then we need to self-isolate for the days that we've been asked to. You know, for us to support our wider communities, it's really important that everyone takes that personal responsibility and follows the government guidance. It is really clear now what we need to do, and so my one ask is to ensure that we all do speak to our communities and call people out. You know, it's not easy to stay at home, but it really is important that we do stay at home for those required days to protect our communities and to protect the NHS.
Absolutely agree. That's absolutely on message, Tanya. Something we should all be doing. So there being no more speakers, can I just say again, well, just ask you actually, are there any points that you'd like to clarify or you'd like to add a little bit more detail to Tanya, Trish and Deborah?
I don't think so. It has yet again been a fantastic committee meeting to attend, so thank you very much for the interest that you've taken into this winter plan and for the range of questions. You know, I will make sure that the questions that we have not been able to respond to in full, you do get a full response after this committee meeting, and that you will get the red, amber, green status report. There's a great interest around mental health, so thank you for that. And so I would like us to think about how we kind of bring mental health to the table as a singular agenda item for next committee. I think both in this committee and our previous one, we have made reference to mental health and mental health support, not just around hospital discharge, but the support to individuals in the community. So it will be good to get a steer from committee so that we can bring in colleagues from PFT and the voluntary sector, so that it's a really good wide range discussion, not just about the local authority responding, if that's okay.
Okay. That would be really useful, and we'll get our heads together on that. And we're looking at the work programme next, so we'll really put our heads together and make sure that comes forward, because as you say, it's there in the back, well, not in the background, it's at the forefront now. I think everybody is talking about the impact on you know, communities in terms of their mental health, and when we come out of this, you know, what is going to be available, what needs to be available, more importantly, what should we be planning for in the future. So yes, absolutely. So can I say thank you once again for this report, for the members' contribution and the questions that they've asked. The recommendations are to note and support the report and the actions taken. I think we've also said that we'd like to see a little bit more detail around the action plan, if that can come back. I'm just looking to see what else we're being asked. Sorry to do.
Chair, if I might.
Yes, please do, Daniel. I'm struggling with my rummaging through my papers. They're all over the table at the moment.
You wanted a bit more detail as well around capacity breakdown across the county,
Yes.
which is going to be supplied, and you wanted a little more detail around training levels as well, particularly around domiciliary care.
Yeah. Thank you. Is that okay, Tanya?
Absolutely, that's great, thank you.
So thank you very much for attending this meeting and giving up 2 hours of your very valuable and precious time. We'll now go on to the next item of the agenda, and that's the Future Work Programme. I'm going to ask our Scrutiny Officer, Daniel Webb, to present that item, please.
Thank you, Chair. Daniel Webb here, the Scrutiny Officer here at Shropshire Council. We are rapidly approaching the end of the municipal year, and of course with that comes elections. So at the moment we only have 2 more meetings planned for this municipal year, in late January and in March. You've asked for quite a bit more information to come back with regards to the winter plan to your next meeting, which is unfortunately not until the end of January. So I might suggest that perhaps the committee undertake that work in between the meetings and report that back to the January meeting, rather than waiting until January to get that information where it can't really do as much with it. So I will work with officers to put that in train with the committee's agreement, of course. It's asked for some further information around the Improve Better Care Fund as well, and Tanya's already alluded to providing a bit more information around that to the future meeting. You've also asked for, at your previous meeting in September, for an update on proposals for the development of the Joint Strategic Needs Assessment, so I'll chase that with the Director of Public Health in time for that meeting.
Yeah, I think that's quite important.
Okay, and then finally, you've asked for a report back, which I will be briefing Deborah Webster with later this week, on domiciliary care. In particular, he wants to look around the impact of COVID-19 on the provision of domiciliary care. In particular, he wants to look at brokerage patterns in terms of demand and supply, and as you've already alluded to earlier in the meeting as well, you wish to look at a bit more detail around the extent of training available for this sector.
Yes, that would fit in well with that.
Indeed. There are other items on the agenda, particularly with regards to January and March. You wanted to look at commissioning arrangements within a single commissioning structure. Whether or not this would be best within this committee and the Joint Health Committee, I think is perhaps one for you and the committee to decide.
Yeah.
You also have a commitment in March to reviewing the 111 services, in here particularly with regard to cross-border arrangements with NHS Wales.
Yeah.
As well, so
I think my view, looking at the I don't know how other members of the committee feel, but looking at the items so far for January, I think I would actually consider the arrangement for a single commissioning structure to go to joint HAOSC, as it is something that is of interest, obviously, with the single CCG. I would think that would be better asked of the joint scrutiny. Otherwise, we're trying to get an awful lot with some really meaty subjects into a short period of time. How do other members of the committee feel? Kate, I see you agree. Thank you.
Yeah, I agree also, Chair.
Okay, thank you.
Yes, I
So,
agree, Chair. I'm looking at the 22nd of March, page 6, Future Fit and Patient Transport Services.
Yeah.
Bearing in mind that'll be the last meeting before the elections, should we do, ought that to be a joint HAOSC meeting as well as?
Yes. Yeah, I think so. I don't know whether my counterpart over in Telford and Wrekin will be particularly pleased for me to be offloading all these pieces of work into the joint HAOSC, but as I'm co-chair, you know, I'll have that conversation with him. I do think it's important to be looking at the memorandums of understanding for substituted services, because obviously after the election this committee is going to change its membership considerably, and so I think it's important that we look at this whilst we still have that knowledge fresh in the mind of the committee, rather than, you know, a completely new committee coming in and looking at it and really thinking, well, you know, what's all that about, without understanding the impacts and implications of the historical context, if you know what I mean.
I'd agree with that.
So I think that is quite important that we look at that. Are there any other comments from members around the work programme as it's standing at the moment?
No.
Chair?
Yeah.
I've just sent you a little message on the chat.
You're going to look at the NHB.
New homes bonus. It's in the.
Oh, right, sorry. Yes, I was totally out of. Yeah.
Of course, the new homes bonus earned by building new homes doesn't end up back in housing. It ends up in another committee on the another department on the 5th floor of Shire Hall, which is supposed to talk about transformation and support in the community. Last year was £2.2 million, and I'm just going to be asking some questions of, are we getting value for money? But we're earning it. Are we getting value for money for it?
Yeah, where's it going?
Well, it's my project for this week.
Keep that, Simon.
It was going into revenue, actually, a lot of it. There was a big chunk going into revenue.
Yeah, it's not
perhaps
a
be a topic for the Communities Overview Committee, Chair?
Yeah, it does sound like it. It's straying into that area. Are you on Community Services Overview, Simon?
No.
Maybe have a chat with Daniel outside of this, because this could be something that Community Services would want to look at.
Yeah, I can see Cecilia, Councillor Motley, being very interested in this topic.
Yeah, I can.
Yes. So that is my pet project for this week. Don't forget, this amount of money is not ring fenced. It just comes in and gets bounced around.
Yeah.
Well, let's bounce it then.
Okay.
Okay, well, if there are no more comments to be made on the work programme, I'm accepting that there are no more comments. Everybody's happy with it.
Yes, I'm happy. Oops.
Thank you. So thank you for that, Daniel.
No problem. I will amend and circulate.
Thank you. I'll draw to an end then and ask the live link to be taken down. Again, thanking members for their participation and the officers for their support.